How AI ready are you? Begin or advance your knowledge with the case based courses in the RSNA Imaging AI Certificate Program. Gain the skills and confidence you need to meet the future of medical imaging through our foundational, advanced, and new emergency certificates. Streamline clinical workflows, accelerate your career, and enhance your earning potential. Learn more at rsna.org/AI-certificate.
Hi, everyone. Welcome back to another RSNA Radiographics podcast. My name is Lily Wang, and I'm a neuroradiologist from the University of Cincinnati. Today, I have a special guest, Dr. Alisa Kanfi, my neuroradiologist colleague at the University of Cincinnati. She's a longtime friend, and she's board certified in both neuroradiology and pediatric radiology, but her heart belongs to the brain. So thank you for doing this with me, Alisa.
Thank you. No problem. And you are also the best.
All right, so today we'll be discussing this beautiful article by Dr. Lillian Lai and colleagues from the Department of Radiology at the University of Iowa Steve Family Children's Hospital. It's entitled Neuroimaging of Neonatal Stroke, Venous Focus. So what I love about this article was that it broke down the patterns of hemorrhage that we commonly see on perinatal MRI images and how it relates to venous thrombosis and infarcts. So let's dive in and take a look. All right, so how common is perinatal strokes, Alisa?
They are very common. The article quotes that there's a prevalence between 1 in 2,300 to 1 in 5,000 births for perinatal strokes. Not only is it common, but it can also result in lifelong morbidity for the patient. So it is important for us radiologists to recognize strokes both clinically and on imaging.
So are venous infarcts the more common strokes in the perinatal period?
Actually, no. About 80% of perinatal strokes are arterial strokes. These are identified by our clinical colleagues, with the presentations of seizures being most common, about 80 to 92%, or encephalopathy. However, 40% of patients have nonspecific or no symptoms of stroke at the time of the event and can only be detected later on when they're missing their developmental milestones. Arterial strokes in the perinatal period are similar to adult strokes in that they are often in a vascular territory, with the middle cerebral artery being the most commonly affected. An interesting fact that is unique to the perinatal arterial strokes is that paradoxical emboli can occur where the thrombus actually originates in the fetal systemic venous system or the placenta, and then it migrates into the fetal or neonatal arterial system through a patent foramen ovale or ductus arteriosus.
Oh, whoops, I've already forgotten there's another foramen ovale in the body.
Actually, there is, but the most important one is in the head, where V3 comes out.
Okay, well, we'll ignore the other one for now. All right, so workup and treatment for perinatal arterial ischemic stroke, how should we approach that?
It's the usual imaging. An MRI of the brain is best, and adding an MRA using non-contrast 3D time of flight technique is the standard. Interestingly, the use of thrombolytic therapy and slash or mechanical thrombectomy are usually not recommended in the neonatal period due to the theoretical risk and the insufficient data to support their use.
See, okay, let's get to the meat of this article. It focuses on venous strokes. So do venous strokes present differently than arterial strokes for clinical colleagues?
Similar to arterial strokes, venous infarcts are also difficult to detect clinically, and they have very nonspecific neurologic signs such as encephalopathy, lethargy, apnea, or poor feeding. It is only during imaging that we can discover or suggest that this may be due to a venous stroke.
Well, given that, what's the best way to image these venous infarcts?
Sometimes you're lucky enough to pick up the infarct or venous thrombosis on cranial ultrasound, but the next step or the best test would be an MRI with a contrast enhanced MRV. The benefit of the contrast enhanced MRV is that it eliminates a lot of artifacts, signal loss from slow flow or aliasing or other flow gaps. If there is intraventricular hemorrhage or thalamic hemorrhage in a full-term neonate on ultrasound, it should raise the concern for cerebral venous sinus thrombosis, and an MRI should be the next step.
Yeah, even in adults, I definitely like the contrast MRVs. It's certainly very
Agreed.
helpful.
Agreed.
Yeah. So
Yeah,
can
the
you
artifacts.
yeah, I know the non-contrast not it sometimes raises more questions than being helpful. So can you tell me some risk factors for venous infarcts in the neonatal period?
How much time do we have? Just
Well,
kidding.
no, just
Risk
let's
factors.
summarize, please.
There are many. There are many. Risk factors for venous infarcts include gestational diabetes, preeclampsia, chorioamnionitis, sepsis, dehydration, difficult delivery, underlying prothrombotic state, prematurity, or incomplete development of a venous network, to name a few.
Venous anatomy. Well, this is very important. And at this point of the podcast, I strongly encourage everyone to read the article for the beautiful graphics. But Dr. Kanfi, can you walk us through it?
I will try.
Well, let's start with the best known, the dural venous sinuses.
The dural venous sinuses are between the layers of the dura, and they are the final venous drainage before joining the internal jugular veins and going into the neck. The posterior superior group contain the superior sagittal sinus, the inferior sagittal sinus, the straight sinus, the torcula hierophili, which I always thought was heterophili, but it's not, it's hierophili, the transverse sinus, sigmoid sinus, and jugular bulbs. So that is the posterior superior group. There's also an anterior inferior group, which includes the cavernous sinus, superior and inferior petrosal sinuses, clival venous plexus, and the sphenoparietal sinus. Interestingly, in the neonatal period, there is often the occipital sinus, and that regresses over time into a venous channel along the falx.
Okay, so how does the brain drain to the dural venous system? Can you break down the deep and the superficial venous systems?
Yes, I'll try again. The deep venous system is an outside in system, which is drained by the vein of Galen. The deep white matter, the basal ganglia, the thalami, and choroid plexus are all drained by the deep venous system.
Okay, can you elaborate?
Yes. The deep medullary veins join centrally towards the ventricle to the subependymal veins, then to the internal cerebral veins by the foramen of Monroe. Then the internal cerebral veins run posteriorly along the velum interpositum, where they get tributaries, the direct lateral and medial lateral veins. And then they all join with the vein of Galen, which joins with the inferior sagittal sinus and into the straight sinus.
I think this creates a very useful mental image of things going the outside in towards the midline. So what is the basal vein of Rosenthal that I hear some people love?
That's a very popular vein. The basal vein of Rosenthal is special because it drains the superficial structures, the cortex and the subcortical white matter of the insula and hippocampus, both important structures, but it also drains the deep structures, the deep white matter, the ventral basal ganglia and thalamus, choroid plexus of the temporal horn. The basal vein of Rosenthal arises in the suprasellar cistern, collecting the anterior cerebral vein, the deep middle cerebral vein, and the inferior striate vein. Then the basal vein of Rosenthal joins with the vein of Galen.
Well, there are some of these little small veins I have never really heard about or remembered from the article.
Yeah, most of us are probably not mentioning them all in our MRV reports. It would make for a very long and
Hopefully
detailed.
not.
But everything in the brain needs some sort of venous drainage. The deep middle cerebral vein collects drainage from the ventral aspects of the brain, including the insula through the insular vein and the hippocampus through the inferior ventricular vein, and the ventral parts of the basal ganglia and thalamus. The choroid plexi also need drainage. The lateral ventral choroid plexus drains via the superior choroidal vein and then into the internal cerebral veins. And the temporal horn choroid plexus drains through the posterior choroidal vein into the basal vein of Rosenthal.
Okay, so that was the deep structures going from outside in. So how about the superficial system? Is it inside out?
It is inside out. It is inside out or centrifugal. So the cortex and subcortical white matter goes through superficial intracerebral veins, superficial medullary veins, subcortical veins, and intracortical veins that then drain into cortical peel veins in the subarachnoid space.
Okay, tell me more about these superficial veins. Does that include Trolad and Labbé?
Indeed, it does. There are about 8 to 12 superficial cortical peel veins over the surface of the cerebral hemispheres, and those all drain into the superior sagittal sinus. The big one along the central sulcus is the vein of Trollard. The vein of Labbé, the other favorite named vein, that collects smaller veins from the posterior lateral surface of the temporal, parietal, and occipital lobes, and then that drains into the transverse sinus. There is a superficial middle cerebral vein along the Sylvian fissure, and that collects veins from the temporal, frontal, and parietal opercula. It's lesser known than Trollard and Labbé, but it is also important. The superficial middle cerebral vein initially drains into the transverse sinus in development, but then actually it changes to the cavernous sinus in the perinatal period.
Someone once told me that Trollard is the top one, so that, and then Labbé is the lower one, and I think it just stuck with me since then. It's easier to remember.
Yeah, not
Otherwise
many
it's-
people talk about that superficial middle
No,
cerebral vein, but
unfortunately, that one is kind of forgotten. I need to it needs someone's name on it, and then we'll have to remember
exactly.
it. So, is there a connection between the superficial and deep venous drainage systems?
Yes, there are two types of bridging veins. There are anastomotic medullary veins, which are short bridging veins between the superficial and deep medullary veins. And then there's transcerebral veins. That connects the peel veins on the brain surface and the subependymal veins. In premature infants, and where we get into a lot of trouble, is that the medullary venous system is not fully developed, and thus they are more susceptible to venous congestion and white matter injury.
Thank you for outlining that important venous drainage map, and thank you to the authors for highlighting the anatomy on great images. So, when a vein thromboses in an infant, what happens?
Well, it depends. If it is a preterm infant, the transverse sinus is the most common sinus affected, followed by the superior sagittal sinus. In a full-term infant, it is usually a multi-sinus thrombosis. And the result of this thrombus could be varied. It could be hemorrhage, infarct, white matter injury, any and all of the above. When there is a cortical vein thrombosis, in addition to a dural sinus thrombosis, there is a higher likelihood of ischemia or hemorrhage.
Recognition of hemorrhage pattern is important and can be a good tip off that you are dealing with sinus thrombosis. So, what patterns should we know?
This was a very important and interesting part of the article for me because I think this pattern recognition can really help the radiologist start thinking that we may be dealing with venous infarct or venous
Yeah, I mean,
sinus
sometimes you only
thrombosis.
have a CT, so that's like when you need to start suspecting.
Right. So if there's involvement of the parasagittal cortex and the subcortical white matter, think superior sagittal sinus. If you see bilateral thalami, bilateral thalamic hemorrhage, or signal abnormality, think about straight sinus thrombosis. If there's hemorrhage in the basal temporal lobe, tentorium, or cerebellum, you may be dealing with a transverse sinus thrombosis. These are all dural sinus thrombosis patterns that I started with.
All right. Well, what about the deep vein thrombosis patterns? This is a little bit unusual.
Yes. The thrombosis of the internal cerebral veins can result in a thalamocaudate pattern. It looks like an arc of hemorrhage in this region, sometimes larger, but it can start as like a little arc between the thalamus and the caudate nucleus. The basal vein of Rosenthal thrombosis can result in a striato-hippocampal pattern, and the deep medullary veins, that can result in a brush or iris, like the flower, not the eye, type of pattern.
Okay.
I really encourage everyone to look at the article because they have great images highlighting the appearance of these hemorrhages.
Yeah, I mean there was a great pearl in this article. Well, one of many, but it said that if there was a intraventricular hemorrhage in a full-term neonate, then we should look for deep venous thrombosis.
Yes, intraventricular hemorrhage in a preterm infant can be relatively common, very common. We see it all the time from germinal matrix hemorrhages. But in a full-term neonate, we need to be thinking about thrombosis of the deep venous system that may be draining the choroid plexus. Between 31 and 63% of full-term infants with intraventricular hemorrhage were found to have thalamic hemorrhage and venous sinus thrombosis in a study that was reported.
So what about the hemorrhage pattern for our favorite named superficial cortical veins, Labbé and Trollard, and what's the other one?
The superficial middle cerebral vein.
Okay, what are their
Ending.
patterns? Well,
Yeah.
I'm going to try to remember that now.
Well, the hemorrhage, again, relate to the areas that they are draining. The vein of Labbé can result in temporal, parietal, and occipital lobe hemorrhages. The vein of Trillard would be a temporal and parietal lobe hemorrhage, maybe more superficial and superior. And the superficial middle cerebral vein would be the opercula of the temporal, frontal, and parietal lobes.
Okay, actually, I just had an idea that makes it easy to remember. You have the top one with Chola, and then you have a middle one, the superficial middle cerebral vein, and you have the lower one, the Labe. So there you go. I think I'll remember.
There you
it
go,
from now.
solving problems left and right.
So I want to spend a little more time on the deep medullary veins and venous congestion. I feel like we see this often, and recognizing this pattern could be important.
Yes. The congestion of the deep medullary veins can be seen in both preterm and full-term infants, and it is related to impaired venous drainage into the subependymal veins. In preterm infants, grade 4 intraventricular hemorrhage and periventricular hemorrhage from germinal matrix hemorrhages, that can compress the deep medullary veins. In full-term infants, the congestion is often due to intraventricular hemorrhage, deep venous thrombosis, or HIE. Congestions of these deep medullary veins has also been associated with comorbidities such as encephalopathy, infection, hypoglycemia, congenital heart disease, and prothrombotic disorders.
Okay. Well, in addition to seeing the brushstroke or the tubular congested medullary veins frequently, I also feel like we see those punctate white matter lesions in the perinatal MRIs. The authors did a great job describing these. So, what is the pathogenesis of these punctate white matter lesions?
Ha! Trick question on your part. We don't know the pathogenesis. We think that they are multifactorial, including small areas of white matter injury that may be related to arterial or venous ischemia, infarct, or gliosis. But you're right, we see these often. Oftentimes, we'll see those tiny punctate T1 hyperintense signal abnormality. Those that have associated signal loss on susceptibility weighted imaging are felt to be hemorrhagic in origin. Those that are clustered and have no abnormality on susceptibility weighted imaging are felt to be more ischemic in etiology. The ones that are hemorrhagic on susceptibility weighted imaging are postulated to be small venous infarcts.
Okay. So, there's another thing that's unique to neonates, subpeel hemorrhage. So, what is this?
Well, this is also of an unknown pathogenesis and it's felt to be multifactorial, but it is often seen in term infants with a vaginal delivery. And it is the accumulation of hemorrhage in the potential space between the pia mater and the brain cortex. It has been described as having the ice cream scoop appearance.
Ice cream. Well, the weather is certainly pretty good for an ice cream scoop right
I'd
now.
be up for some ice cream. The other symbol that you might like associated with the subpeel hemorrhage is the yin and yang, and that's describing the hemorrhage associated with diffusion signal abnormality in the underlying or adjacent cerebral cortex. Congestion or thrombosis of the superficial medullary veins and subdural, subcortical, and subarachnoid hemorrhage can all be seen in combination with this subpeel hemorrhage.
What's the treatment for cerebral venous thrombosis in neonates?
I leave the treatment decisions to the NICU teams.
Yeah, we
because
don't want radiologists treating
I don't want
this.
to overextend myself. But in all seriousness, there are a few important things I would like to highlight about the treatment of cerebral vein thrombosis in neonates that was highlighted in the article, and that is different than adults. Anticoagulation therapy is a reasonable treatment option, even in the presence of hemorrhage. This, again, we will leave to our clinical colleagues to evaluate on a case-by-case basis. The other thing is that there's insufficient evidence for more invasive therapies at this time. Interestingly, complete recanalation occurs within 3 months in about 90% of patients. And repeat imaging is important to evaluate to assess the evolution.
Oh, well, I love repeat imaging, especially if shows it goes away.
Me too. Me too.
Well, thank you so much, Dr. Kanfi, for your time. I really enjoyed talking with you about neonatal cerebral venous thrombosis and strokes. So let's go and get some ice cream.
That sounds wonderful. Thank you for having me. This was a great article, and I was happy to be a part of this podcast.
Yeah, please go and look at the images online and the RSNA Radiographics website. Thank you.